So
change again.
Good morning everyone. Myself Premanand. My roll number is 91. Today me and my friends are going to present the topic cardiology, which is assigned to us as a seminar topic. So first of all, I would like to thank all the teachers who have given the topic cardiology. It is a very wonderful topic, and we will try our best to explain it. So let us dive into my topic. My topic is pericardium. So what is pericardium? It is basically a fibroserous sac which encloses the heart and the root of the great vessels. So let us go to the next slide. So let us understand the anatomy and functions of the pericardium. Pericardium, as I told the definition, so see, it is located in the middle mediastinum. It is a space present between the two lungs. Here you can see the lungs, and it is posterior to the sternum. Here is the sternum, and it is present above the diaphragm. Below the lungs, you can see the diaphragm. See here, you can see it clearly. And what are the functions of the pericardium? It protects the heart, and it acts as a shock absorbent, and it prevents over distension of the heart and fixes heart and reduces the friction. Let us go to the next slide. So layers of pericardium. Basically, pericardium has a fibrous layer. Pericardium is composed of two components. First is the fibrous pericardium, and second is the serous pericardium. So this one is the fibrous pericardium, and here you can see it is the serous pericardium. Serous pericardium is divided into two layers: the parietal pericardium and the visceral pericardium. The parietal pericardium is attached to the fibrous pericardium, and the visceral pericardium is adherent to the heart, and therefore it is also known as the epicardium. So let us go to the next slide. Blood and nerve supply of the pericardium. The arterial supply of the pericardium is the pericardiophrenic artery, musculophrenic artery, and the branches from the thoracic aorta. Venous drainage of the pericardium is from pericardiophrenic veins and from the azygous system. The nerve supply of the pericardium, the parietal pericardium and the fibrous pericardium are supplied by the phrenic nerves, which are pain sensitive, and the visceral layer of the serous pericardium is supplied by the autonomic nerve, therefore it is pain insensitive. So the next topic, development of the pericardium. So as 1 minute, sir. So I will explain it by this. So this is a suppose this is a heart tube. This is the arterial end, and this is the venous end of the heart tube. So suppose here is the pericardial cavity, which is separated from the pleural cavity by the pleuropericardial folds. So this heart tube, invaginates into the pericardial cavity from the posterior wall, and what it starts winding around itself like in this way. So what happens here? You can see there is a dorsal mesocardium which is connecting the arterial end and the venous end of the pericardium of the heart, and it is in the embryonic stage, and later it disappears and leaving a space here called as transverse sinus. So we will discuss about the sinus later. So you can see the visceral layer and parietal layer, they both are formed, and the fibrous pericardium. So the pericardial cavity is basically formed from the intraembryonic xylem, and you can see that the fibrous pericardium is formed from the somatopleuric mesoderm, the fibrous pericardium, and the parietal layer of the serous pericardium, and the visceral layer of the serous pericardium is formed from the splanchnopleuric mesoderm, and the septum transversum contributes to the fibrous pericardium. So now let us talk about the sinuses of the pericardium. As I told you, this is the arterial end and this is the venous end, which coils like this, and here leaves a space. So this is nothing but it contributes to the transverse sinus. So it has a surgical importance in cardiac surgery for the ligation of the great vessels. We can pass the finger and ligate the great vessels, which are ascending aorta, pulmonary trunk. And the another sinus present is the oblique sinus. pulmonary veins which are combined in the embryonic stage, they start to separate and leaving a space behind them, which is called as the oblique sinus. It is a curly sinus, it is a blind sac, it is a natural sinus, it prevents the dysphagia. As you can see, the posterior relation is the esophagus. So what happens, it is a left atrium. Whenever it expands, it can compress the esophagus, but because of this oblique sinus, it prevents the compression of the esophagus and therefore prevents dysphagia. So let us go to the applied aspect. The pericarditis, it is the inflammation in the pericardium. You can see a healthy pericardium and a pericarditis. Here you can see the inflamed part. The reason is this is due to the infection, TB, or it can be due to autoimmune causes. It causes the chest pain and pericardial friction rub. Second one is pericardial effusion, excess fluid in the pericardial cavity. Reason is the infection, malignancy, and trauma. Here you can see the excess fluid. And next one is the cardiac temperament. It is a type of pericarditis. There is a rapid fluid accumulation which compresses the heart, thereby decreases the cardiac output. The patient usually present with a sign known as Beck's triad. It causes hypotension, distended neck veins, and muffled heart sounds. And the last one is the pericardiocentesis. This is the needle aspiration of pericardial fluid by it is done at the level of the left, fifth, or sixth intercostal space near the sternum to aspirate the pericardial fluid. So thank you. This was all from my side. So next will be done by my.
Regular mic use करो unless you want to use your phone.
ते खालीच राहू दे.
Good morning, everyone. Hello. Yeah. So good morning, everyone. I am Tisha Agrawal, roll number 92, and I will describe the features of the right atrium and right ventricle. So first of all, the right atrium receives deoxygenated blood from all parts of the body, and it is the upper right chamber of the heart. It receives blood from the superior vena cava and the inferior vena cava. It forms the right border, the part of the upper border, the sternocostal surface, and the base of the heart. It then pumps blood into the right ventricle through the AV valve, and the right ventricle receives the deoxygenated blood from the right atrium. The right ventricle forms the inferior border, the 2/3 part of the sternocostal surface, and 1/3 part of the inferior surface of the heart. So, for the external features of the right atrium, it has on the left side it forms a So on the left side it forms a lateral appendage. It is known as the right auricle, and it receives blood from the superior vena cava over here, the inferior vena cava.
Fine.
Over here, the coronary sinus, the anterior cardiac veins, the Thebesian veins, and on the right lateral right border there is a groove called sulcus terminalis. It is formed due to an internal ridge called the crista terminalis. On the upper side of the sulcus terminalis is present the SA node, which is the pacemaker of the heart, and there is an atrioventricular groove which separates the right atrium from the right ventricle. The internal features of the right atrium consists of three parts: the sinus venereum, the pectinate part, and the interatrial septum. The sinus venereum has the opening for the superior vena cava, the opening of the inferior vena cava, which is regulated by the rudimentary valve called the eustachian valve. In the embryonic stage, the eustachian valve guides the blood from the right atrium to the left atrium through the fossa ovalis, and it also has the opening for the coronary sinus. The pectinate part is the rough anterior part of the heart, which is embryologically developed from the primitive ventricle. It contains crista terminalis, which is an internal ridge, and from it arises transverse ridges called musculospectini, and they give the right atrium the look of a teeth of comb. And then we have the interatrial septum, which contains the fossa ovalis, which is the remnant of the septum primum, and then we have the annular fossa ovalis, which is the remnant of the septum secundum, and we also have the triangle of Koch. The external features of the right ventricle. So it has two surfaces, the anterior or the sternocostal surface, or the inferior, and the also known as the diaphragmatic surface. It is triangular or pyramidal in shape, and it is separated from the left ventricle by an interventricular groove, and it is separated from the right atrium by an atrioventricular groove. It leads to the pulmonary trunk, which sends the deoxygenated blood to the lungs for oxygenation, and its wall is thicker than that of the left ventricle in the ratio of 1:3.
Thinner.
The internal features of the right ventricle. So internally, the right ventricle consists of three parts.
Just go back. The last line, wall is
Thicker.
Thinner than the of the left ventricle, the ratio of 1:3.
The left ventricle
Yeah.
wall is thicker.
Sorry. And the internal features of the right ventricle. So it consists of three parts: the inflowing part, which is the rough part, which is developed from the primitive ventricle, and the outflowing part and interventricular septum. So the inflowing part consists of trabecular cardi, which are elevations of the right ventricle. There are three types: ridges, bridges, and pillars. So papillary muscles is an example of pillars, which connects the wall of the right ventricle to the AV valve by the caudate tendinae. The moderator band is an example of a bridge which connects the interventricular septum to the anterior papillary muscle, and there's this opening of the tricuspid valve. The outflowing part consists of the pulmonary orifice, which is guarded by the semilunar valve, and the supraventricular crest, which is between the tricuspid and the semilunar valve. And we have the interventricular septum, which consists of two parts of the anterior muscular part and posterior membranous part. The posterior part divides the not only the two ventricles but also the right atrium from the left ventricle, and the anterior muscular part divides the two ventricles. So as I said, we get the rough outflow part of the right atrium from the primitive atrium, and the rough outflow part of the right ventricle from the primitive ventricle. Thank you. Now I would like to call Priyanshu for describing the left ventricle.
Good afternoon everyone. My name is Priyanshu. My roll number is 93. Today I will be presenting about left atrium and left ventricle. So let's start with introduction of left atrium and left ventricle. Left atrium is a quadrangular structure. It is situated posteriorly. It receives oxygenated blood from lungs through four pulmonary veins, and it drains into left ventricle. From the left ventricle it is pumped into aorta. Now let's start with external feature of left atrium. Its appendages called as left auricle, which project anteriorly to overlap the infundibulum of right ventricle. The left atrium forms the left two-thirds of base of heart, sternocostal surface, greater part of upper border, part of sternocostal and left surface and left boundary. The posterior surface of left atrium forms the anterior wall of oblique sinus. Now the clinical significance of this oblique sinus is that, as we know, esophagus is present behind the oblique sinus. So it prevents from esophageal compression due to atrial enlargement, as in case of mitral stenosis. So now let's discuss the internal feature of left atrium. Anterior wall is formed by interatrial septum. This septal walls of fossa called as fossa lunata, which corresponding to fossa ovalis of right atrium. Posterior wall has 4 openings for pulmonary vein. The greater part of atrium is smooth, which is derived from absorbed pulmonary vein. Muscular pectinity are present only in auricle, where they form reticulum. The part developed from primitive atrial chamber of heart tube. Now let's discuss about external feature of left ventricle. It forms the apex of heart, sternocostal surface, and 2/3 of left diaphragmatic surface, and most of the left border and left surface. It is conical walled and thick. Externally, left ventricle has 3 surfaces: anterior, inferior, which is also called as diaphragmatic, and left surface. Now let's discuss about internal feature of left ventricle. So left ventricle is divisible into 2 parts: lower rough part and upper smooth part, which is also called as aortic vestibule. Lower rough part contains trabeculae carni, which is also called as recess of heart. It developed from primitive ventricle of heart tube. Upper smooth part gives origin to ascending aorta, and it is developed from mid portion of bulbous cordis. There are 2 orifices in left ventricle: atrioventricular orifice, which is guarded by mitral valve, and aortic orifice, which is guarded by aortic valve. There are 2 well-developed papillary muscles, which are also called as pillar of heart. Chordae tendini from both muscles attached to both cusps of mitral valve. The cavity of left ventricle is circular in cross section, and wall of left ventricle is 3 times more thicker than wall of right ventricle. Thank you.
My name is Rachna and roll number 95. Today I'll be talking about ventricular assist devices. So what is a ventricular assisting device? It's a mechanical pump supporting heart functions in end-stage heart failure. So when there's heart failure, the heart is too weak to pump blood efficiently on its own. So we need a separate device for it. So the ventricular assisting device pulls the blood from the ventricle and moves it to the aorta or pulmonary artery, bypassing the failing part of the heart. Internal pump, it consists of an internal pump, a cable that passes through the skin, and an external controller with battery packs. But why do we use a ventricular assisting device? It is used as a bridge to transplant. It is used as a bridge to transplant therapy. So when a person is waiting for heart transplant, when he has gone through cardiac failure, then till the person gets the transplant, a ventricular assisting device can be used for that person. It is used as a destination therapy. So when there is a shortage of donor hearts, the ventricular assisting device can be used as the final form of treatment for the cardiac failure of that patient. Bridge to recovery. So when the cardiac failure is temporary and there is scope for recovery, then we don't go for a heart transplant, but a VAD is attached to help the person recover. Types of VADs. So VADs have evolved through 3 generations to improve durability, size, and patient outcomes. So the first generation are pulsatile pumps. So these consist of large and noisy pumps. They use electrical mechanisms to simulate a heart contraction and to create a pulse. So it consists of chambers which are present inside the body with valves where the blood goes inside and then comes out through pneumatic and electrical signals which simulate a pulse in the body, basically a contraction and relaxation of the heart. So there are many infections and mechanical failure due to moving parts can happen, so it's not preferable. The second generation VADs are continuous flow axial pumps. So instead of a pulse, we have a continuous flow of blood over here. They are smaller and more efficient. They consist of an internal rotor and a drive line which generate a continuous flow instead of a pulse. Third generation are continuous flow centrifugal pumps. They use magnetic levitation to suspend the impeller. Magnetic levitation also known as maglev. So when the mechanical parts of the LVAD are suspended, there is no friction between the parts and the blood. So many conditions that can happen, so the blood thrombosis or any blood conditions are all reduced. Artificial heart. So when there's total heart failure, we need an artificial heart. It's the complete mechanical replacement of the heart, not just assistance. It replaces both the ventricles. Advantages are it is used in end-stage biventricular heart failure when both the ventricles are not functioning properly. It is used as a bridge to transplant. So the mechanism is that the blood enters the artificial chambers and the pump pushes it to the lung and the rest of the body. We'll talk about a case over here where a patient survived on a ventilator assisted device for 10 years. So this patient was a 66-year-old male who had a severe heart failure due to myocardial infarction. The left ventricular ejection fraction was 15% and there was an occluded left anterior descending artery. So they first put up a stent, but stent is basically a mesh which holds the artery open. But ventricular fibrillation was seen. There was a clot formed in the stent, because of which catecholamine therapy was given and an intra-aortic balloon pump was also inserted. But the symptoms continued and cardiac arrhythmias were still seen. So the only option left now was to undergo an LVAD implantation. LVAD means left ventricular assisting device because the left ventricle was damaged. So HeartMate 2, a second generation LVAD was implanted over here. So the surgery was successful. It was an uncomplicated procedure. So regular checkups were done for the next 10 years. Lab tests, ECGs and device monitoring was done. Outcome was that there was a very stable LVAD function. The person did not suffer from any stroke or GIT bleedings and there were no major adverse events. There was a driveline infection, but infected tissue was extracted and antibiotic therapy was given. But other than that, it was a very successful operation. Patient did not experience any exercise limitations and was satisfied with the quality of life. So patient did not even opt for a transplant because the life was very satisfactory even with an LVAD. So in conclusion, we can say that VADs can provide long-term survival in selected patients. Obviously, the patients have to be selected and there has to be timely implantation and there has to be regular follow-up and care. In our current patient, the procedure was successful because there was absence of right ventricular failure and even the left ventricular function was partially preserved. So that's why the patient was able to survive for 10 years. But in conclusion, we can say that modern LVADs are reliable cardiac support systems as destination therapy from a long-term perspective. Thank you. Now I'll hand over the mic to you.
So, good morning everyone.
राधा इधर से
So, good morning. I'm going to be presenting on the topic of heart valves. So, let's start. As we know, valves, the main function of valves is to prevent the regurgitation of the blood and to provide the unidirectional flow of the blood. As we know, the main types of valves are atrioventricular valves and semilunar valves. AV valves are further divided into two, the tricuspid and the bicuspid and the mitral valve. Tricuspid valve is between the right atrium and the right ventricle, and the bicuspid and the mitral valve is between the left atrium and the left ventricle. The semilunar valves are of two types, the aortic valve and the pulmonary valve. Aortic valve is between the left ventricle and the greater vessel, that is the aorta, and the pulmonary valve is between the right ventricle and the great vessel, that is the pulmonary artery. All these valves, they are made up of cusps, except the bicuspid valve. All of them have three cusps. The cusps are made up of endocardium and fibrous core. The AV valves, for their mechanism, they have chordate antennae, whereas the semilunar valves, they don't have chordate antennae. We will discuss the role of chordate antennae in the subsequent slides. As you can see in the GIF, as the ventricle is systoling, the semilunar valves are opening and the AV valves are closing. And during the ventricular diastole, the semilunar valves will close and the AV valves will open. Next, let's discuss in detail about the AV valves, that is the tricuspid and the bicuspid valve. First, let's talk about the tricuspid valve. As you can see, the common features in both of the valves are the fibrous ring and the three cusps in tricuspid valve. The anterior cusp, the posterior cusp and the septal cusp. The anterior cusp, as you can see, is larger, the posterior is relatively smaller, and the septal. All three of them, they have a free margin and an attached margin, atrial surface and a ventricular surface. At the ventricular surface and the free margin, with the help of chordae tendineae, they're attached to the apex. They're attached to the apex of the papillary muscles. Papillary muscles, as mentioned earlier, they are pillars present in the internal features of the ventricle. Then comes to the mitral valve. Here you can see two cusps, the anterior cusp and the posterior cusp. The anterior cusp is larger and the posterior cusp is relatively shorter. It is attached to the anterior and posterior papillary muscles with the help of chordae tendineae. Next, as I said, the importance of chordae tendineae and the papillary muscles. As you can see in the picture, in the GIF here, as the ventricle is contracting, the papillary muscles are also contracting, which results in the closure of the valve. Here I can explain you the mechanism. As the ventricle is undergoing contraction, the pressure in the ventricle is increasing. This will lead to the closure of the valves. But if the pressure increases further, it will lead to regurgitation of the blood into the atria, which is not favorable. So here we have the chordae tendineae and the papillary muscles. So when the ventricle is contracting, the papillary muscles will also contract, which will increase the tautness of the chordae tendineae and will pull the cusp of the valve downwards, thereby closing the valve and preventing the regurgitation of the blood. Next is the semilunar valves. Here we talk about the structure and the mechanism. For the structure, here we have, you can see the fibrous nodule which is in the center, and in the peripheral part which is narrower is the lunula. Above, the characteristic feature of the semilunar valves is the pocket, which we'll discuss in the mechanism in detail. And above the pockets here you have the coronary sinuses. As we know, from the left posterior sinus, the left coronary artery will arise, and from the anterior coronary sinus, the right coronary artery will arise. Next, we talk about the mechanism. So we know that during ventricular diastole, the blood will come back to the heart and it will fill in these pockets. First, it will fill in the coronary sinus, through which the blood will go to the coronary arteries. This explains why coronary artery is the only artery in the body which receives blood during diastole. And next is, as the blood comes in, it fills in the pockets, and the pressure in the pockets increases, which leads to opposition of the lunula and the fibrous nodule, which leads to closure of the valves, thereby preventing the regurgitation of the blood. Next is, for the clinical anatomy, we have stenosis and regurgitation of the blood. So main difference between stenosis and regurgitation is stenosis, the orifice becomes narrower, which leads to decreased blood flow from the atria to the ventricle or the ventricle to the great vessels. And in regurgitation, the valves are incompetent, which is they are supposed to prevent the backflow of the blood, but yet they don't prevent the backflow of the blood, and there is a leaking. So in stenosis, there is pressure overload, which leads to hypertrophy, and in regurgitation, there is volume overload. In valvuloplasty, we replace the diseased valve with a prosthetic valve. Now, for the artificial valves, we have two types of valves, that is the bioprosthetic and the mechanical valves. Here, we can think which is better, which is not, but it really depends from case to case and from person to person. If the person, if the subject is older, like beyond 65, 70 years of age, we prefer bioprosthetic valves. That is because they are xenografts, they are porcine valves, and once inserted, they have a lifespan of 10 years, which is relatively less as compared to mechanical valves. And the only advantage of bioprosthetic valve is here there is no requirement of anticoagulants. Mechanical valves, on the other hand, once inserted, they have a lifespan of 20 to 30 years, so therefore the person may not require resurgery, but the requirement is you have to take anticoagulants for the rest of your life, that is warfarin. Next is mechanical valves are of three types, that is the Starr-Edwards valve. So first, you can see this is a ball in a cage. The cage is made up of metal and the ball is silicone ball. It goes away from the opening and allows the blood to flow, and then it comes near the opening, so it will not allow the blood to flow, thereby preventing regurgitation. But here, because the flow is turbulent, it will increase the chances of blood clots, thrombus and embolism, thereby leading to increased chances of strokes. Next is tilting disc valve. Here the disc will tilt to an angle, thereby allowing the blood to flow, and thereby it will again close and prevent the backflow. But here also it has the same disadvantages, that it has a turbulent flow. So today what we use currently is the St. Jude's valve. Here there are two leaflets, as you can see, thereby dividing it into three channels. So the flow is relatively smoother, thereby the chances of clots, thrombus, embolism and stroke is less. So it is used today. Nextly, here the recent advantage, not recent, quite but like it was introduced in 2002. It is transcatheter aortic valve implantation. Here, it is preferred for elderly people wherein open heart surgery is not recommendable. So here what happens is a catheter is introduced to the femoral artery and a collapsed valve is introduced. It is guided via the catheter to the aortic valve, and here it displaces the aortic valve. The aortic valve is not removed, it is only displaced. And here this is most common method that is used in aortic stenosis to correct the stenosed valve. Thank you. Now I would like to call upon Rahul for the next.
Good morning to all. Myself Rahul, roll number 96. Today I am here to talk about a specialized and synchronized system present in the heart along with other closely associated topics. Before beginning, let me give you all a description about the seminar. The above mentioned system have involved with electrical conducting system along with how they are conducting in
Mic
the,
pass.
how the electrical impulses are conducting all over the heart. So they are based there. Heart is endowed with two different types of system: the conducting and the generating system. The generating system involves which generates rhythmical electrical impulses to cause rhythmical contractions. Conducting system, this impulse rapidly pass through the heart, functions on the conducting system. The atria contract about 1/6 of a second ahead of the ventricular contraction, thus allowing filling of the ventricles before they pump the blood through the lungs and peripheral circulation. This is also called the AV nodal delay, about which we will be talking in further slides. Allows all portions of the ventricles to contract almost simultaneously, essential for most effective pressure generation in the ventricular chamber. In the given figure, all the structures covered in the green color represents the electrical conducting system of the heart along with some excitable tissue. SA node and AV node are the major excitable tissue present in the heart. Along with these, internodal fibers, Purkinje fibers, right and left bundle fibers are also involved in conduction of electrical impulses. As the SA node generates action potential, it is not directly distributed all over the cardiac musculature. There is a AV nodal delay. AV node fix in a delay which is required for the ventricular contraction. It is because
चलने
let's hop on to SA node. SA node consists of a specialized crescent-shaped structure present in right atrium. It is placed in the matrix box present near the crista terminalis of right atrium. When the action potential is generated in SA node, they are directly distributed all over the ventricles because the atrial cardiomyocytes are directly connected to the SA node. Here we can see that. But in case of ventricles, there is an AV nodal delay. As AV node, in the previous slide, as here we can see, the time of travel of impulses along the AV node is solely 0.13 seconds, whereas for the internodal fibers is 0.03 seconds only. This represents the AV nodal delay. For Purkinje fibers, they are very large fibers. They are larger than the ventricle muscular fibers. Their conduction speed is also very high. There are almost 6 times of that seen in the ventricular fibers and 150 times of that seen in atrial nodal fibers. This high conduction speed is necessary because of requirement of instantaneous electric potential after the AV nodal delay. For the ECG, electrocardiogram, it is used to record the electrical activity of the heart. When there is atrial contraction, prior to that is atrial depolarization. So this atrial depolarization is basically the electrical impulse that is generated in the SA node and is travel to the atrial musculature. So the electrocardiograph is basically the device or machine which is used to record the electrocardiogram. So electrocardiograph uses 3 different types of leads, like lead 1, lead 2 and lead 3. For lead 1 and lead 2, the negative terminal of the electrocardiograph is connected to the right arm, lead 1, positive terminal is on the left arm, and for lead 2, the positive terminal of the graph is on the left leg. For lead 3, negative terminal is connected to the left arm, and for the positive terminal is connected to the left leg. We also use precordial and augmented limb leads. For precordial, we have 6 different types of leads named V1 to V6. V1 and V2, all of these leads are placed superficial to the body. V1 and V2 are placed right and left border of the sternum in 4 intercostal space respectively. V4 lead is placed on the mid-clavicular line on the left side of 5th intercostal space. V3 is placed midway between V2 and V4. V5 and V6 are placed on left side in 5th intercostal space along the anterior axillary and mid-axillary line respectively. For the augmented limb leads, when the positive terminal is connected to the right arm, it is called AVR lead. AVL lead is when the positive terminal is connected to the left arm, and AVF lead is when the positive terminal is connected to the left leg. This represents the normal ECG of a person. The ECG consists of 3 different types of waves: P wave, QRS complex wave, and T wave. The P wave represents the atrial depolarization wave, which anticipates the atrial contraction. For the QRS complex wave, we can say it is a complex wave because when the impulses are traveling or getting distributed along the ventricular muscle fibers, they are traveling in different directions. When the direction of the nerve of the electrical impulse is in opposite direction of the lead, it records as a negative wave, like seen here. So there are 3 different types of waves seen, which represents ventricular depolarization. The last wave is the T wave, which represents the relaxation wave of the ventricles, which lasts around 0.25 to 0.35 seconds. The concluding part from my side is the artificial pacemaker. Artificial pacemaker is based on the principle of generating electrical impulses to provide a heartbeat when the heartbeat is significantly lower in a person. Artificial pacemaker or pulse generator basically is a box made out of metal placed subcutaneously near the clavicle. It consists of a circuit, batteries and leads. The batteries need to be periodically replaced, and the leads are basically wires that travel through the veins, basically the subclavian vein, to enter the heart and sense and increase the heart rate by providing the impulses that are not generated by the SL node. There are basically 2 different types of pulse generator: wired and wireless. There is no significant difference in wired and wireless, but the wireless does not have any leads and it is placed in the right ventricle of the heart. It is used in 3 different cases, like bradycardia and heart block-like condition. But the biventricular pacemaker is a device which uses the principle of the pacemaker to resynchronize the ventricles in cardiac heart failure. That's all from my side. Thank you.
Good morning everyone, myself Rajni Chillarge, I'm roll number 97 and today I'll be talking about the blood supply of the heart. As we all know, the heart is the blood pumping organ. As we all know, the heart is the blood pumping organ of our body that supplies each and every organ of our body with oxygenated blood and takes away the deoxygenated blood. But have you guys ever wondered how the heart muscles are supplied with oxygenated blood? Well, for this, we have a different circulation known as the coronary circulation. The coronary circulation is a network of arteries, veins and capillaries that together coordinate and supply the heart muscle, that is the myocardium. Now let us see how these arteries are situated on the heart under the heading the coronary arterial circulation. So the coronary arterial circulation starts from the aorta. Our aorta have this aortic sinus, which is also known as the sinus of Valsalva. The sinus of Valsalva is divided into right coronary artery and the left coronary artery. As you can see here, the right coronary artery runs into the atrioventricular groove and divides into the marginal artery and a posterior interventricular artery. The posterior interventricular artery is also known as the posterior descending artery because it goes on the posterior side of the heart and descends downwards towards the apex of the heart. The right coronary artery, together with its branches, supplies the right side of the heart and also this sinoatrial node.
You have written the arise from the ascending aorta and get divided into 2 main branches. So there is a single trunk and then dividing?
Yes, from the ascending aorta, the aortic sinus, which is also the sinus of
There is
Valsalva.
single stem which gives rise to to right and left?
Is there only
नाही,
one
नाही, दोन
sinus
ऑस्टिया
or
आहेत ना,
there
दोन
are
separate
more
ऑस्टिया आहेत.
aortic
There are two separate osteos. The anterior
Yes,
and
ma'am.
the posterior. Coming to the left coronary artery, the left coronary artery also divides into two branches. That is the anterior interventricular artery and the circumflex artery. The circumflex artery supplying the lateral wall of the left ventricle and the left atrium, and the anterior descending artery, which is also known as the anterior interventricular artery, supplies the anterior wall of the left ventricle and the interventricular septum. This artery is also known as the widowmaker because if there is any blockage in this artery, which it will lead to severe myocardial infarction. Well, now after the arterial circulation, we come to the venous drainage. The venous drainage, the myocardium,
The whole distribution of each coronary artery. Distribution means one left coronary artery will supply what all structures of the heart, right one will supply what all parts of the heart.
And branches.
SA nodal artery, conus artery also, and inter.
Detailing of the left coronary artery and the right coronary artery.
So coming to the venous drainage of the heart, the venous drainage starts from the capillaries. The capillaries take the deoxygenated blood to the venules, and the venules to veins. And these veins drain the deoxygenated blood into an even bigger vein known as the coronary sinus. This coronary sinus is supplied with major veins known as the small cardiac vein, the middle cardiac vein, the greater cardiac vein, and the posterior vein of the left ventricle. About 80 to 85% of the deoxygenated blood is supplied to the right atrium by the coronary sinus. Now what about the rest 15 to 20? The rest 15 to 20% of the blood is taken to the right atrium by the Thebetian veins. The Thebetian veins are small veins which are present on the periphery of the myocardium. It covers the whole of the heart, and it takes blood directly and it takes deoxygenated blood directly from the myocardium to the right atrium. This is all about that we learned until now. The left ventricle, when it pushes the blood, when it undergoes systole, it pushes the blood into the ascending aorta. The ascending aorta to the right coronary and the left coronary artery. From the right coronary artery, it goes into the marginal and the posterior interventricular artery. And from the left coronary, it goes into the anterior interventricular and the circumflex artery. From these arteries, it supplies the myocardium, and from the myocardium, all these veins take the deoxygenated blood to the coronary sinus and ultimately to the right atrium. After the coronary circulation, we come to a new topic, that is the venous return of the blood. What is venous return? By definition, it is the total amount, that is the total volume of the blood that is returning to the right atrium per minute. But what is its significance? Like, why are we even measuring the volume of right atrium? Because if we understand venous return, we can also determine and understand the cardiac output. Any change in this venous return will be ultimately reflected in the cardiac output. There are certain factors which affect the coronary venous return. Some of which that are listed here are skeletal muscle pump, cardiac suction effect, respiratory pump, pressure gradient, and blood volume. After this, we have development of cardiac veins. During the embryological period, our heart has a system known as the embryonic venous system. This embryonic venous system has two parts: sinus venosus and an epicardial venous plexus. The sinus venosus is like a big chamber which receives deoxygenated blood from different veins like vitelline, umbilical, and cardinal veins. This sinus venosus has two horns, the right horn and the left horn. As the baby develops, this right horn gets incorporated into the right atrium and forms the smooth part of the right atrium, known as the sinus venolum, and the left horn forms the coronary sinus and the oblique vein of the left atrium. After this, we have epicardial venous plexus, which is a network of veins that reorganizes and form major veins like small cardiac vein, great cardiac vein, and the middle cardiac vein that are going to drain into the coronary sinus. There are certain anomalies. If there is any defect in the development of these structures, it will lead to certain anomalies. First of which is the persistent left superior vena cava. So what happens in the embryonic life is that we have a left anterior cardinal artery and vein, and a right anterior cardinal vein. These drains blood from the upper part of the body into the sinus venosus. Now what should developmentally happen is that the right anterior cardinal vein will form the superior vena cava and the left anterior cardinal vein should regress. But if due to any defect the left anterior cardinal vein do not regress, or if it persists, it will lead to formation of an extra superior vena cava, which will lead to this anomaly. These anomalies are often undetected during the early stages because it is asymptomatic.
After this, we have coronary sinus atresia. It simply means the failure in the formation of coronary sinus, which will lead to impaired blood drainage. Another anomalies are total or partial anomalous cardiac venous drainage, which is quite rare in human cases. Thank you. That was all from my side.
अंजाइना और इस्कीमिया और कोई कवर करने वाला है?
हाँ,
मायोकार्डियल इस्कीमिया
इसमें लिया है, हिस्टोलॉजी में लिया है।
सेपरेट है।
हाँ। हो चालू
Good morning everyone. Myself Sumit Rankhame. I am going to speak a few words on counter pulsation techniques, that are EECP and IABP. So what is basically counter pulsation technique? These are techniques that are useful for therapeutic purposes for patients who suffer from diffuse coronary perfusion and are provided with external machines which help in increasing the coronary perfusion. EECP is nothing but enhanced external counter pulsation, and IABP is intra-aortic balloon pump. Both mainly work on the diastole during the diastole to increase the blood flow to the coronary arteries. Let's learn in detail about the working of EECP. So EECP is uses the cuffs around the lower limbs of the body. There are three different cuffs which are wrapped around the thigh, the calves and the buttock region, and during the diastole of the heart they contract and push the blood towards the heart, increasing the coronary perfusion. It works like squeezing the toothpaste from the bottom of the tube. EECP therapy may also be recommended for people who need a procedure to restore blood flow to their heart and aren't eligible for a surgery due to their ongoing medical conditions. As you can see, there is a ECP machine. There are different cuffs which are attached to the lower limbs of the body, and they are also monitored by ECG and blood pressure, which help in the proper synchronization to the heartbeat and diastole of the heart. Next, we come to intra-aortic balloon pump. It also works on a similar principle, that is provides the coronary perfusion during the diastole of heart. It has a small, long, skinny balloon which is placed into a patient's aorta, the large artery carrying blood from the heart to the rest of the body, specifically in the thoracic aorta. As you can see from the animation, the balloon inflates and deflates according to the diastole and systole of the heart. We can see a short video which explains it in detail.
क्लिक कर
Aortic balloon pump, or IABP, is an inflatable balloon that is surgically implanted into the aorta to help the heart pump blood to the body and to help improve blood flow to the coronary arteries. When the heart is at rest, the balloon inflates, helping the blood flow through the coronary arteries to the heart muscle. When the heart begins to contract, the balloon rapidly deflates, causing the blood from the heart to flow more forcefully into the aorta and out to the body. This device can be used for patients who have recently had a heart attack or are waiting for a heart transplant.
As you can see how it explains why it works only in diastole, as if it contracts or inflates during the systole, it may cause additional pressure on heart and disrupts all its function.
क्लिक करते खालचं क्लिक कर बटन कर ना
We can see the various clinical applications of EECP and IABP. So EECP is mainly used in ischemic heart disease, heart failure, post-revascularization patients, and peripheral vascular benefits.
And while IABP is used in patients of cardiogenic shock, acute myocardial infarction complications, unstable angina, and preoperative cardiac support. There is a comparative chart between these two procedures as we can compare that EECP is non-invasive as there is no involvement of surgery or opening of the body, while IABP is a major process and involves major surgery. There are also different devices such as VAD and a whole operating theatre required for operation of it. EECP is mostly prescribed to chronic cases in which patients have no benefits due to ongoing treatment and used as therapeutic, while IABP is used in emergency situations such as myocardial infarction to help in restoring the blood flow during surgeries. The EECP main function and role is to improve coronary perfusion, while IABP main role is to provide hemodynamic support. That's all from my side. I would like to call Prasad to take over.
हे घेते ते चेंजर घेते ते चेंजर घ्या चालच नाही का बॅटरी गेली वाटते त्याची
Good morning everyone. Good morning everyone. Myself Prasad Rashinkar, roll number 99, and my topic for the seminar is cardiological investigation on echocardiography and angiography. Let's start from the basic. What is cardiac imaging? Cardiac imaging is basically the procedure which are used to monitor the heart for the diagnosis and the management of the heart diseases. They are used to access the cardiac structure, blood flow, and any type of coronary artery patencies. There are two major modalities under this. The first is echocardiography and second is angiography. Now, echocardiography is basically the non-invasive procedure which uses the ultrasound for obtaining the real-time images of the heart. And the working principle of it is the patient is firstly lying down on a bed and the ultrasound probe that we call as a transducer is placed on his chest wall. Then the signals are sent to the walls of the heart and the reflected signals are captured by the transducer and the corresponding echocardiogram is obtained. Now there are three types of echocardiography: transthoracic, transesophageal and Doppler echocardiography. In transthoracic echocardiography, the probe is placed on the chest wall, and in transesophageal echocardiography, the probe is inserted into the esophagus. And in Doppler echocardiography, it basically used to assess the speed and direction of the blood flow. As we can see in the diagram, the waves which are towards the probe are indicated by yellowish orange, and the waves which are away from the probe are by the bluish color. Now, what it evaluates by the echocardiography? Echocardiography basically evaluates the size and structure of the heart, valve functions, and basically the ejection fraction, which has a physiological importance. Now there is a test called as a treadmill test or exercise stress test, in which a person, when at rest on obtaining his echocardiogram, we cannot see any blockage or any abnormalities on his echocardiogram. But when he does exercise and we count his echocardiogram by wounding a PP cuff around his elbows, we get some abnormalities or any type of heart blockages from that. There are certain positive findings like ST segment elevation depression, abnormal BP findings, and then arrhythmias and chest pains. Now the second modality we will study is the coronary angiography. In coronary angiography, opposite to the echocardiography, it is an invasive procedure to visualize the coronary arteries by using catheter and the X-rays. In which the catheter is firstly inserted into the easily accessible arteries like femoral arteries and radial arteries, and this catheter is then guided towards the coronary artery by passing through the blood vessels. After reaching the coronary artery, the dye is injected into coronary artery, and by using X-ray, the corresponding angiogram is obtained. As we can see, the dark staining due to the injection of the dyes, which basically predicts that any type of blood flow, any type of heart blockage is there. Now the uses of coronary angiography will study in subsequent slides. Now there are types of angiography like cerebral angiography, coronary angiography and peripheral angiography. As the name suggests, the coronary angiography are for evaluation of the heart vessels, cerebral for the brain vessels, and similarly peripheral for heart upper and lower limb vessels. Now what we can evaluate from the coronary angiography is that location and severity of the blockages, blood flow, how the blood flow is from the vessels, and any type of aneurysm of aorta or the major blood vessels. Now the clinical applications of the cardiac imaging is that for echocardiography, it is used for monitoring of the myocardial infarction, congenital heart diseases and ischemic heart diseases. And for the angiography, it will be the chest pains or aneurysm of vessels or any type of arrhythmias. And majorly it is for atherosclerosis, that is coronary artery disease. Okay, thank you from my side. Now Bruce will take over after this.
ये प्रीवियस स्लाइड से वो दोनों सेम है कि डायग्नोसिस ऑफ कोरोनरी आर्टरी डिजीज एंड इस्केमिक हार्ट डिजीज नहीं बड़े ये दोनों सेम है कि अलग अलग इस्केमिक हार्ट डिजीज और कोरोनरी आर्टरी अलग
Good morning everyone. My name is Rushabh Surje, roll number 147, and my topic is CT and MR angiography. So first we will see what is angiography. Angiography means imaging of blood vessel to detect any blockage, aneurysm, any narrowing in the blood vessel. And it includes conventional catheter angiography, in which the catheter is injected, and we will see the blood vessels by this. And MR and CTA is non-invasive alternative of the CT conventional catheter angiography. Here we can see the normal coronary artery and the narrowed coronary artery. CT angiography. Principle of CT angiography. CT angiography is work on the principle. It uses X-ray with iodinated contrast dye to produce detailed image of the blood vessel. So basically, the iodinated based contrast dye is injected into the blood vessels, and the multiple image and rapid image are taken by the CT scanner, and it then reconstructed into by the computer, and the complete vessel is found, where we can see any aneurysm or any blockage. Indications of CT angiography. It is used to detect vessels narrowing, blockage, identify aneurysm, acute emergency like pulmonary embolism, aortic dissection or stroke. Pulmonary embolism means the arteries of the lungs get blocked or get damaged. Aortic dissection means the aorta, inner layer of the aorta get damaged, and the blood surge into the layer in between the layers of the aorta. And the stroke, where the brain damage, where the blood vessels blocked and the blood cannot pass into the brain. Likewise, vascular injury in trauma, congenital vascular abnormalities are also can be seen into by the CT angiography. Now, contradiction of CT angiography. In certain conditions where there is risk and risk involved like severe adenoid contract allergy or severe renal failure, the MR is cannot be done. And
CT can.
but with knowing causes, the MRA can be done in moderate kidney disease, pregnancies, metformin use if kidney function is impaired, dehydration, hyperthyroidism, and multiple myeloma. CT angiography is used to detect pulmonary embolism, aortic aneurysm, coronary artery disease, and peripheral artery disease. These are the commonly used in CTA. Advantages and disadvantages of CT angiography. CT angiography is very fast, so it used in emergency cases like strokes and trauma. It have higher spatial resolution and widely available. And disadvantages are exposure to ionizing radiation, alienated contrast is cause allergy, not ideal in renal impairment. Now we will see MR angiography. MR principle. It uses magnetic field and radio waves to visualize blood vessels and their flow. It can be done with contrast or without contrast. If the contrast is used, it is gadolinium because it does not cause any allergy. Indications of MR angiography. And MR angiography is used in arterial stenosis, aneurysm detection, stroke evaluation, congenital vascular abnormalities, venous disease, aortic dissection, or in the case if the person is allergic to the iodinated contrast dye, the person is preferred to do MR instead of CT. Contraindications of MRA. If the person have implants like pacemaker, cochlear implants, and aneurysm clips, and foreign metallic bodies like especially in eye and brains, the MR cannot be done. But with knowing causes in conditions like severe renal failure, pregnancies, especially first trimester, claustrophobia, where the patient have fear of small spaces and inability to lie. The inability to lie still if the sedative are given. And MR angiography is commonly used in brain vessels, aneurysm, AV malformation, carotid artery disease, congenital vascular abnormalities, and follow-up imaging. Now you will see advantages and disadvantages of MR angiography. There is no radiation involved and safer in renal impairment and good for soft tissue and for flow assessment. Disadvantages are severe and more expensive, gadolinium risk in severe renal failure and less available. Thank you from my side.
Good morning everyone. Myself Rohit Rathod, roll number 100. Roll number 100.
Change kar.
Today I am here to speak about the angioplasty and bypass procedures.
तोंडाजवळ ठेव माईक. हे बघ.
I am here to
असं
speak
तोंडाजवळ
about,
माईक.
Today I am here to speak about the angioplasty and bypass procedures. So let's begin. Angioplasty. Angioplasty is a treatment procedure to restore the blood flow in narrowed or blocked arteries, which is narrowed or blocked due to the plaques and blood clot. Plaques and blood clot are caused due to the high cholesterol levels, fats, or calcium. Angioplasty is a minimally invasive procedure which is not as much invasive as bypass surgery is. It is also called as percutaneous transluminal therapy. Its duration is 30 minutes to 3 hours. There are some indications where we perform angioplasty, such as emergency heart attack, in which immediate intervention to open blocked arteries and minimize damage to the heart carrier. And then severe coronary artery diseases, there are blockages of major epicardial vessels such as right coronary artery, left anterior descending artery, or circumflex artery, which is the branch of left anterior descending artery. Then there are persistent symptoms such as angina pectoris, which means chest pain. Then critical vessel diseases, which is obstruction 50% or more in left main coronary artery, and peripheral artery diseases. Now let's begin with the procedure of angioplasty. Suppose a patient come with the chief complaints like chest pain, which is diverting towards the left shoulder. Then patient is immediately admitted and monitored with cardiac monitors, and intravenous sedative are given to relax their body. Then a needle is inserted through the wrist in the radial artery, which is used for the ticking pulse. Then a guard wire is then passed to pass the guard wire through it. A guard wire is then passed through the needle up to the heart. Then a flexible catheter is slipped over the wire guided up to the heart. Guard wire is removed as the tip of the catheter reaches the coronary artery. Then
guard wire or the guide wire?
Guide wire.
Guide wire.
Guide wire.
Okay.
Then a special dye is injected at the site of the catheter, and with dye helps the fluoroscope to take X-ray images of interior of coronary artery. This helps to identify the position of block called angiogram. As blockage is identified, flexible guard wire inserted into the artery, followed by balloon tip catheter. The balloon tip catheter is inflated and deflated rapidly, which causes opposition force against the plaques and the blood clot, which restores the blood flow. As you see in the figure B, the balloon tip catheter is inflated and deflated rapidly, which restores the blood flow, as you see in figure C.
Next.
Then there is another method of angioplasty, which is stent angioplasty. It is mostly similar as that of the balloon angioplasty, but in this case, instead of using a balloon tip catheter, we use stent. Stent is a wire mesh which is tube shaped, as you see in the figure B and C. Then stent deployments involves navigating a catheter-based mesh tube to a blocked artery or vessel, expanding it via balloon or self-expansion, and ensuring wall opposition. Then key stent deployment steps. Let us discuss the deployment steps in stent.
लास्टचं वाच फक्त शेवटचं.
In deployment and expansion, suppose a balloon expandable, a balloon is inflated to expand the stent against the vessel walls, and the stent is also expanded by the self-expanding by external force given to the stent, which expands it and restores the blood flow. Let us discuss next procedure, which is the coronary artery bypass graft. Coronary artery bypass graft performed to improve circulation to heart muscles in severe blockages. it is more invasive that of the angioplasty because it needs incisions on the chest. In a single operate, we can carry out one or more CABG, this is coronary artery bypass graft.
Next slide. Go to next slide. Just-
As you see, the blockage is severe from the angioplasty case. The artery is almost blocked. Then you can see the graft there, which is internal thoracic artery graft. In case of coronary artery bypass graft, we use healthy vein or artery, which is where we take the graft. In case of internal thoracic artery, the proximal end is connected to the first part of subclavian artery, and the distal end is connected beyond the blockage, so that we restore the blood flow. There are two types of the coronary artery bypass graft surgery. That is on pump, in which the heart is stopped and is supported by the machine, that is cardiopulmonary machine or the heart lung function machine, and the off pump, in which the heart is beating, but we reduce the potential of the heart, so that it can beat slowly. Then this procedure may take approx 4 to 6 hours. Thank you.
Slide change करो.
Good morning everybody, my name is Razan Riaz Mullah. Today I am going to present the topic histology of heart and an overview on the stem cell therapy. So this topic is important because understanding the microscopic structure of the heart helps us correlate structure with function, and also gives us insight into the there are 3 layers of the heart: endocardium, myocardium and epicardium. Each layers have the specialized structures, and which all of those contribute to the function of the heart. Let us start with the endocardium. The innermost lining is formed by simple squamous epithelium, which is called the endothelium, and under it we have subendothelial connective tissue and smooth muscles and elastic fibers. The deeper layer consists of Purkinje fibers, which helps in the conduction of electrical impulse for the heart. So the function is smooth blood flow, which is contributed by the simple squamous epithelium, and conduction support, which is contributed by the Purkinje fibers. So here we can see Purkinje fibers. To be more specific, the Purkinje fibers are present in the subendocardium. And let us move to the myocardium. It is the thickest layer and the functionally most significant layer in the myocardium. It is composed of cardiac muscle fibers. The features of the cardiac muscle fibers are striations, they are branched, they have 1 to 2 single central nucleus, and the key feature is intercalated disc. These intercalated discs consist of fascia adherents and desmosomes. These two helps in adhering the adjacent cells, and the gap junctions helps in the communication between the adjacent heart cells. The function of the myocardium is contraction. So here we can see the intercalated discs. Lipofuscin granules are present near the nucleus. We have central nucleus. Then we will see it more when we will study the cardiac muscle histology. Now let's move to the epicardium. This is the outermost layer of the heart wall. It is composed of mesothelium on the outer side, and then below it we have connective tissue. This layer contains blood vessels. Then we have autonomic nerves which regulate the heart rate. Then we have adipocytes. We also have nerve bundle, autonomic nerve bundle. We have mesothelium. You can see the adipose tissue. Then we also have epicardial connective tissue below it. The function of epicardium is protection and lubrication while cardiac movements. So before moving to the cardiac muscle histology, let us see some properties of cardiac muscles, like autogenicity, the ability of heart to initiate an impulse without any external stimulation. Then excitability, the ability of the heart to respond to stimulus and by generating a propagated action potential. Then conductivity, to conduct the impulse, and contractility, to contract in response to the stimulation. there is one more property that cardiac muscle have very limited regeneration capacity. Now let's see the cardiac muscle histology. Here you can see the intercalated discs. Then we have single central nucleus. Then we can see the branchings. We can see the striations. Then there can be max 2 nuclei. Basically, simply we have single central nucleus.
Play them.
So these are the working of the gap junctions. So we can see the intercalated disc. It has gap junctions. How the molecules are transported. How the conduction happens. Now let us talk about the conducting system of the heart. These are formed by Purkinje cells. These are specialized cardiac cells. They have large cytoplasm. They are pale staining due to their as they are glycogen rich, and they have fewer myofibrils because their main function is not contraction, it is conduction. So hence they have fewer myofibrils. So to be specific, they are located in the subendocardium just below the endocardium, and the function is rapid impulse conduction. We can see the animated image. Then we can see the histological image. Your Purkinje fibers, glycogen receptor cytoplasm. Now let's talk about the clinical correlation. So in pathological conditions like myocardial infarction, death of cardiomyocytes, necrosis occurs due to ischemia, and due to the limited regenerative capacity of the cardiomyocytes, fibrous tissue, scar formation occurs. Now these fibrous tissue, they don't have the property of contractility, so hence it compromises the cardiac function and there is less regeneration. So we can see the process. In the initial stage, there is correlative necrosis.
Sorry, go back to the one slide back.
One slide back.
These are Purkinje cells, not Purkinje fibers. Because the Purkinje cells are also somewhere else.
The brain. Cells में.
Where Purkinje cells are there? Important cells.
So you can call them Purkinje myocytes.
So this thing is important too.
Here you can see in the initial stage there is formation of wavy cardiomyocytes, then there is loss of nuclei, and in the final stage we can see the collagenous scar forming, scar tissue replacing the most of myocytes. Now let's talk about stem cell therapy. So as we know, there is limited regenerative capacity of cardiomyocytes, so this stem cell therapy is a promising regenerative therapy. So let's we have some more introduction to stem cells. They are undifferentiated cells characterized by the ability to self-renew and to differentiate into specialized cells. They can be classified into 3 types: embryonic, adult, and induced pluripotent cells, stem cells, iPSCs. The goal is to regenerate damaged myocardium, the cardiomyocytes that are damaged, and to improve the cardiac function. The types of stem cell used are bone marrow stem cells. These are the most commonly used stem cells. Then we have mesenchymal stem cells, we have cardiac stem cells, iPSCs. These are naturally present in the heart but are limited in number. So we can see these are the extra, we also have embryonic stem cells that can be used over here. Now the mechanism of action. The therapeutic effects of the stem cells are mediated to multiple mechanisms, like we can see differentiation into cardiomyocytes, then release of paracrine effects, growth factors, then we have cardiac stem cells. There will be also angiogenesis, formation of new blood vessels. So methods of delivery. So initially, typically the stem cells are harvested from the patient, then they are processed under controlled conditions and laboratory conditions, and then they are introduced in the heart of the patient through various routes like intracoronary injection, intramyocardial injection, intravenous route, transendocardial route. So here you can see the diagram. In that we have multiple methods to do it. The advantages is that it helps in potential regenerating of the cardiac muscle cells, heart tissue, and some methods are minimally invasive. But there are challenges.
मैं निकल जाता हूँ, उस स्लाइड निकल जाता हूँ.
Thank you. Now I would like to call Isha Zuberi to continue with the further presentation. Thank you.
Let's try.
Good morning everyone, I am Isha Zuberi, and now we'll be starting with the embryology of the cardiovascular system, in which I will be discussing vasculogenesis, angiogenesis and the development of primary heart tube. So the cardiovascular system is the first system to start functioning in the embryonic life, and it starts in the 3rd week, and what happens is in the around second week, the embryo is deriving its nutrition through diffusion from the extraembryonic serum and from the yolk sac as well. So since as the size of the embryo is growing, it cannot be sufficient that it derives its nutrition and oxygen only through diffusion. Therefore, there is a need for the development of separate vascular system. So essentially, the it is derived from the splenopleutic mesoderm. So when I say that it's derived from the splenopleutic mesoderm, I mean the primordium of heart is majorly derived from the splenopleutic mesoderm. There are other parts as well from which it is derived as the pharyngeal mesoderm and the neural crest cells. So there are different processes that are occurring like vasculogenesis, the formation of primitive heart tube, etc. that we'll discuss. So when we're talking about the development of the vascular system, there are majorly two processes that we'll be discussing. The first is the vasculogenesis and the second is angiogenesis. Vasculogenesis essentially means the de novo formation of the blood vessels. So what happens is, these are the mesenchymal cells of the splenopleutic mesoderm. These mesenchymal cells get differentiated into angioblastic cells. These angioblastic cells form aggregates and clusters and form blood islands. Now these blood islands, there will be formation of cavities in these blood islands like these, and these cavities will then later coalesce to form a singular vessel. So these are the primitive vessels. And one thing to note is that the angioblastic cells are the only ones which will be forming the endothelium of the blood vessel. And as discussed earlier, the blood vessel also has muscular and fibrous components. Now the muscular and the fibrous components are derived from the mesenchymal cells that are lying here, and these are at times derived from the neural crest cells as well. So here we can see that at the beginning of the third week, the vasculogenesis has started in the umbilical vesicle, the connecting stalk, and here in the chorionic sac, and approximately 2 days later it will start in the splenopleutic mesoderm, which is the embryo proper as well. Then we have the process of angiogenesis. After vasculogenesis, angiogenesis occurs, which is the expansion of the vascular network. So what happens is, the endothelial cells that have already formed, these will branch out and sprouting will occur, and these will form a vascular network. So to summarize, we can call that the vasculogenesis basically the formation of the blood vessels de novo, while the angiogenesis the formation through pre-existing ones. We can say that the function for the vasculogenesis is establishment of primary vascular network, whereas the angiogenesis is modification and expansion of the vascular network. Also, another thing to note is that the vasculogenesis, the stage of occurrance is in the early embryonic period, while for the angiogenesis it is occurring throughout life as the need for perforation increases in our body. Now coming to the formation of the endocardial tube. So the induction for the formation of the heart is through the endodermal cells, and these endodermal cells will induce the formation of heart. So in the epiblastic cells, the primitive streak, the epiblastic cells lateral to the primitive streak are called as the cardiogenic cells. These cardiogenic cells will travel through the primitive streak and then migrate to the cranial part of the splenopleutic mesoderm, where they'll form this horseshoe-shaped cardiogenic area. Here in the cardiogenic area, as discussed, they will be forming the vessels, which is vasculogenesis. So there are two bilateral vessels that will be formed, which will be called as the endocardial tubes. And these endocardial tubes will later fuse in the cranial part and they'll form a horseshoe-shaped like structure. So can I use the word? So here, say for instance, this here is our yolk sac and this is the endoderm. This is our tube that is formed, and here we'll have the mesoderm, and this here is the septum transversum, and here is the ectoderm. So here we can see this portion is the foregut, and here we'll be having the oropharyngeal membrane. Here is the septum transversum, and somewhere here will be the pericardial cavity. So what happens is, here this is a very simplified version of the same. So somewhere here we'll have this foregut, here we'll have the oropharyngeal membrane, behind or rather dorsal to the endocardial tube is the pericardial cavity, and here is the septum transversum. Now the lateral and caudal, craniocaudal folding.
और एक क्लिक पीछे लो, और एक क्लिक करो. हाँ, पीछे जाओ, पूरे पहली स्लाइड पे जाओ, उसके पीछे वाली स्लाइड पे जाओ. हाँ, आप फिर से क्लिक करो और एक बार क्लिक करो और छोड़ दो.
So here the lateral folding has occurred. and then the craniocaudal folding has occurred. Now we can see the relative positions of the structures, where this is the primitive heart tube. Behind it, or rather dorsal to it, is the foregut. Here is the oropharyngeal membrane. Here will be the here is the pericardial cavity, and this is the septum transversum, which will go caudally to it.
क्लिक करके छोड़ दो.
Now, this is the ectoderm that was not there in the previous diagram, and this is the foregut, and here is the pericardial cavity. We can also see the septum transversum caudally to it, and this is the dorsal mesocardium when the primary heart tube is invaginated into the precardial cavity. This is the somatopleuric mesoderm, and here is the splanchnopluric mesoderm. Splanchnopluric mesoderm also contributes to the formation of the elongation of the primary heart tube. And then the primary heart tube then develops 4 dilatations, and then the cardiac looping occurs, and formation of atria and ventricles occur, which will be discussed by the subsequent presenters. Thank you.
Good morning all my dear friends. I am Roshan John, roll number 25103. Now we will be discussing about the development of atria, how the atria develops and they will be separated. So for that, first we will be discussing about the structures of atria. There are 2 atria, that are right and left atrium. Right and left atrium both has the two walls, that is rough anterior wall and the smooth posterior wall. The rough anterior wall in both the right and left atrium is made up of the muscular pectinity, and the smooth posterior wall here in the right atrium is made
something.
This smooth posterior wall has of the right atrium has the superior vena cava, inferior vena cava, and coronary sinuses. And these rough and smooth posterior walls are being separated by the crista terminalis from the inside, whereas sulcus terminalis will be seen from outside of the heart. Now the left atrium also has the rough anterior and smooth posterior wall. Here the smooth posterior wall has the pulmonary veins, and this left atrium and right atrium are being separated by an interatrial septum, and this has oval regression called as fossa ovalis. Now the heart is being heart develops from the heart tube. So here we can see the structure of heart tube. This is sinus venosus, this is primitive atrium, this is primitive ventricle. So here the primitive atrium and sinus venosus comes from behind of the primitive ventricle in the embryonal development, such that the primitive atrium opens into the primitive ventricle through the atrioventricular canal, as you can see here. You can see that primitive atrium is at the posterior side of the primitive ventricle. So coming to the next slide, that is atrioventricular canal. Here in the atrioventricular canal, the cushions start developing from both the anterior and posterior surface, that is superior endocranial cushion and inferior endocranial cushions.
Cardiology.
So after that, this continues developing, and this both will be fused. So we will get 2 openings, and they will be having their respective walls. So now discussing about the development of interatrial septum. For the interatrial septum, on the roof, from the roof of the atria, the septum primum start developing. It will go downwards like this, and when it will go downwards, we will have the small opening called as the foramen primum. So then it will continue to go down, and this foramen primum will be closed, start closing. So we will there will be perforations in the wall, and foramen secundum will be start opening. And from here, then afterwards, the septum secundum will start developing in the front of septum primum, in front of the foramen secundum. So such that we will have the this foramen ovum, this foramen ovum, and this earlier that was the septum primum that will be converted into wall of the foramen ovuli. Here, this was in the embryonal stage. Here, the blood flows from the right atrium to the left atrium. So, after the blood, when the pressure in the left atrium increases, this wall of the foramen ovuli moves backward, and this will give us the fossa ovalis here. So, now discussing about the right atrium, rough anterior wall was, as discussed earlier, was from the primitive atrium, and the smooth posterior wall was from the sinus venosus. Here, the sinus venosus has the left and right two horns. They will be having three veins, and these three veins will regress, and this umbilical vein will regress, and this common carotinal vein will develop into superior vena cava.
Yes. Common cardinal vein.
Common cardinal vein will develop into superior vena cava, whereas this vitelline vein will develop into the inferior vena cava for the right horn. Now, the these oblique veins of the left atrium and coronary sinuses of the left horn will open into the right horn of the sinus venosus, and sinus venosus is also receiving blood from the superior vena cava as well as the inferior vena cava. So, the smooth posterior wall of the right atrium is formed by the absorption of right horn of the sinus venosus, whereas the left horn remains as the coronary sinus and the oblique vein of the left atrium. The main objective was that the rough wall comes from the primitive atrium, and the smooth posterior wall is from the right horn of the sinus venosus. If we look at the inside of the right atrium, the sinus venosus opens into right atrium through the sinoatrial orifice. The orifice has two walls, the left venous wall and right venous wall, and it has dorsocranial support that is called a septum superior. This septum superior, septum spurium and left venous wall will move this side and will be developing into interatrial septum, and this right venous wall, its superior portion will degenerate and its inferior portion will convert into the walls of coronary sinus and inferior vena cava. Now, last slide. This development of the left atrium. So here, for the right atrium, the rough part was developed from the primitive atrium, same is here, and initially the left atrium has the opening of the stem of pulmonary veins, which are formed by 4 branches. All the stems get absorbed into wall laterwards, and this will form the pulmonary veins absorbed, and this will form the smooth posterior wall.
Good morning everyone, I am Ronak Sahu, roll number 104. Today I am going to be presenting the development of ventricles and great arteries. In this presentation, I will be covering the embryological origins, key steps involved in the ventricular formation, then septation, development of cardiac valves, and development of great arteries and the faith. Embryological origins of the ventricles.
How many slides you have? 7 to 8.
To begin with, the right and left ventricles are derived from two main components, the primitive ventricle and the bulbus cordis. Bulbus cordis is the cranial portion of the primitive heart tube, and it consists of 3 portions, the proximal, middle and the distal. The middle portion is called as the conus cordis, and the distal portion is also known as the truncus arteriosus, whereas the proximal one does not have such a name. All these components undergoes development and form specific structures in the adult heart. The primitive ventricle and the proximal portion of the bulbus cordis together form a common chamber known as the bulboventricular cavity. The conus cordis forms the outflow tracts of both the ventricles. These are the smooth balled regions through which the blood exits the ventricles. Then the truncus arteriosus forms the ascending aorta and the pulmonary trunk. Key steps involved in the ventricular formation. After the heart undergoes looping,
there is a basic spatial arrangement established already for the ventricles, and there is a common ventricular cavity. In the ventricular cavity, first of all, the right and the left sides are not separated, so there is formation of interventricular septum. The interventricular septum divides the right and the left ventricles. Simultaneously, in the truncus arteriosus, there is formation of spiral or aorticopulmonary septum. And in the conus cordis, remodeling occurs, and it leads to the left part forming the aortic vestibule, and the right part forming the infundibulum. Now we will discuss the formation of interventricular septum. Interventricular septum consists of three parts. Each part originated from different sources. The parts are muscular, bulbar, and membranous. The muscular part grows upward from the floor of the primitive ventricle towards the AV or endocardial cushions. The bulbar part grows from the chronotruncal or bulbar ridges. The ridges first of all grow towards each other and form a bulbar septum, and then they grow downwards towards the muscular part. However, there is a gap present between the muscular and the bulbar part. They are not fused completely. That gap is known as interventricular foramen. The interventricular foramen is filled by the membranous part. The membranous part is due to the proliferation of the tissue from the right side of the AV cushions and the right and the left bulbar ridges. The membranous part itself has two components, the anterior and the posterior. The anterior component separates the right and the left ventricles, whereas the posterior component separates the right atrium from the left ventricles. In this GIF, we can see in the coronal view the simultaneous formation of the interatrial and the muscular part of interventricular septum. They are growing towards the AV cushion. Now, formation of spiral septum. A spiral septum is found in the truncus arteriosus, and it divides the ascending aorta and the pulmonary trunk. For two chronotruncal or bulbar ridges appear, and they first grow towards each other and fuse helically or spirally. The orientation of spiral septum is such that the relative positions of the aorta and the pulmonary trunk are different at different levels of the truncus arteriosus. For example, in the proximal section, the pulmonary trunk is anterior to the aorta. Then in the intermediate section, aorta is present to the right and pulmonary trunk to the left. And then in the distal section, aorta is present anterior to the pulmonary trunk. So the spiral nature is for the insurance of that aorta connects to the left ventricle and pulmonary trunk to the right ventricle only. Now the development of cardiac valves. Pulmonary and aortic valves, also known as semilunar valves, are derived from the endocardial cushions that are present at the chronotruncal junctions. At those junctions in the walls of the conus cordis, there are bulbar ridges that grow and fuse with each other. As the aortic and pulmonary openings are separated, these cushions are also separated and forms two parts. Both the parts are given to both the openings, and simultaneously there is formation of two more cushions, anterior and posterior. So this way, both the openings have three cushions, and as the development progresses, these cushions develop into cusps. And after this, the outflow tract also undergoes rotation. This rotation is so that the valves also acquire the position that is in the adult heart. For example, like before rotation, the pulmonary valve is only ventral to the aorta, and after rotation, pulmonary trunk shifts to the left of the aorta and is ventral to it. Mitral and the tricuspid valves are formed by the proliferation of connective tissue present under the endocardium of the right and left AV canals. These tissue undergo remodeling and excavation and forms the valve cusps. Now, development of arteries. The first arteries that appear in the embryo are the right and left primitive aortic. These primitive aorta each has three parts. The ventral aorta, which forms the aortic sac, the aortic arch arteries that connects the ventral and the dorsal aorta and are arranged in the pharyngeal arches. And then there is this dorsal aorta, which is present dorsal to the foregut and is responsible for the formation of descending aorta. Now, fate of pharyngeal arch arteries. Most of the aortic arch arteries disappear or regresses, and some remains and persists. So there is selective regression and persistence of the pharyngeal arch arteries. The first aortic arch artery mostly disappears and is in adults can be seen as maxillary artery. The second aortic arch artery is also regresses mostly, and in fetal life can be represented by hyoidal and the stapedial artery, and it may contribute to the formation of external carotid artery. The fifth aortic arch artery disappears completely. So at last the third, fourth and sixth aortic arch arteries only remain connected to the aortic sac. And the spiral septum also extends into the truncus arteriosus such that there is appropriate flow of blood, like from the pulmonary trunk blood flows into the sixth aortic arch artery only, and from the aorta only to the third and the fourth arch arteries. Now there are changes that happens in the arterial arches to produce the adult pattern. So first of all, the dorsal aorta grows beyond the point of attachment of the first arch arteries, and the portion of the dorsal aorta that is present between the third and the fourth arteries, also known as ductus caroticus or carotid duct, disappears, and this portion of the right dorsal aorta between the point of attachment of the fourth aortic arch and the point of fusion of the two dorsal aorta also disappears, only on the right side. And the pulmonary trunk blood flows into the sixth arch artery. The sixth arch artery also gives buds to the developing lung bud. So on the right side, the portion of the sixth arch artery present between the bud and the attachment to the fourth arch artery disappears. Whereas on the left side it persists and is also known as ductus arteriosus. The ductus arteriosus after birth gets obliterated and forms ligamentum arteriosum. The dorsal aorta also gives lateral intersegmental branches to supply the body wall. Now I would like to call Shiley to further continue the
Last.
Hello, am I audible?
Yeah. हो गया
Everybody.
इकडे
The last one that we're going to be covering today,
आतमध्ये.
which is developmental anomalies. And so before this, we've already studied how the heart is developing. A quick recap would include there are two heart tubes. These heart tubes will start fusing from the cranial end towards the caudal end. There is dilation, there is septation, there is wall formation, and then there is looping and folding which occurs, which results in the formation of the mature heart. It seems pretty straightforward. So what could possibly go wrong? This is what could go wrong. You have congenital heart defects. These congenital heart defects can be divided into acyanotic defects, cyanotic defects, and obstructive lesions. Acyanotic defects refer to a defect which results in shunting of the blood from the left side of the heart to the right side of the heart. Why is it known as an acyanotic defect? The reason for that is the left side of your heart consists of oxygenated blood, while the right side of your heart consists of deoxygenated blood. Now, when the blood is being shunted from the left to the right side, the blood which is entering the systemic circulation still consists of the same amount of oxygen saturation. However, the volume is decreased, which can be compensated for by increasing the rate and rhythm of contraction of the heart, which is why you have cyanosis is not a symptom which is seen in this condition. The examples of acyanotic defects will be atrial septal defects, ventricular septal defects, and patent ductus arteriosus. Cyanotic defects, on the other hand, is where your blood is being shunted from the right side of your heart to the left side of your heart. So it involves deoxygenated blood contaminating the oxygenated blood which is present on the left side of your heart. So this will result in the amount of oxygen which is reaching the rest of your body being reduced. This will be implicated in the case of tetralogy of Fallot and transposition of great vessels. Obstructive lesions, on the other hand, involve reduction in the lumen size of your great vessels, which will be the coarctation of aorta and the pulmonary stenosis. Moving on to specific heart defects, you have atrial septal defects, in which, as is clear in the diagram, the defect lies in the interatrial septum, which separates the right atrium from the left atrium. So here the question might be, why does the blood only flow from the left side of the heart to the right side of the heart? There is a hole, right? So bidirectional flow of blood should be possible. However, the defect lies in the fact that the blood which is entering the left atrium, so we've already studied how the septum works. You have a septum primum which is present inferiorly, and you have a septum secundum which is present superiorly. And in a mature heart, these fuse together. However, your septum primum is a more flappy membranous structure, while your septum secundum is a more fibrous cord-like structure. So in this case, when there is blood which has to flow from the left atrium to the right atrium, the blood pushes the membranous flappy structure to move into the right atrium. However, when blood has to move from the right to the left atrium, the fibrous septum secundum will prevent this from happening.
The major characteristic symptom of this condition is a wide fixed splitting of S2. The reason for that is when there is left to right shunting, that means that there is more amount of blood which is present on the right side of your heart. So right ventricle experiences a larger load, which results in the aortic SL walls actually closing a little before the pulmonary SL walls do close, which results in the second heart sound which is produced because of the closure of SL walls being split into two sounds. Moving on, then you have a ventricular septal defect. The ventricular septal defect is a defect in the interventricular septum which divides the right ventricle from the left ventricle. And even here, the shunting occurs from the left to the right side instead of the right to the left side. Here the reason is a little different. The left ventricular musculature involves a physiological hypertrophy because obviously the left ventricle has to push blood into the systemic circulation. So the left ventricle consists of a capability to provide a larger pressure within the ventricular chamber than the right ventricle, which is why blood is shunted from the left to the right side. Will this be the only condition which occurs? Can the blood be shunted from the right to the left side as well? Is something we'll come to soon. Then you have symptoms. The major symptom of a ventricular septal defect involves a loud pansystolic murmur. What does that mean? Pansystolic murmur refers to a murmur which is heard throughout the duration of the systolic period. The reason for this is, if this is my left ventricle, this is the right ventricle and this is the left ventricle. This is your ventricular septum, which involves a patency. There is a hole which is present within the interventricular septum. And if this is the pulmonary aorta, blood has to move from the right ventricle into the pulmonary aorta. At the same time, due to a patency which is present in the interventricular septum, during systole of the cardiac cycle, blood is also moving from the left ventricle into the right ventricle, which results in a lot of turbulence being present in this part of the right ventricle, which results in a murmur being heard in the pulmonary area, which will coincide with the left lower sternal edge. Then we move on to something known as the Eisenmenger syndrome. So Eisenmenger syndrome can result due to various defects in the heart, some of which are, the first one exemplifies an interventricular defect, as we just saw. Then you have, this is an AVSD, that is an atrioventricular septal defect. This refers to a patent ductus arteriosus, which is a communication which is present between the aorta and the pulmonary trunk. And over here is an interatrial septal defect. What is the pathophysiology? Seems pretty complicated, but we can take it down into smaller parts. The main cause can be a ventricular septal defect, a patent ductus arteriosus, an atrioventricular septal defect, and an atrial septal defect, all of which will cause a long-standing left to right shunt, increasing the amount of blood which is being sent to the pulmonary capillaries. On the other hand, you have something known as a patent truncus arteriosus, in which the conotruncal septum is not developing. In this case, there is a right to left shunting. However, the amount of blood still going to the pulmonary capillaries is high, which results in the amount of blood flowing through the smaller capillaries which are present in the pulmonary circulation being increased. And because these capillaries are not having the capability to deal with this amount of stress, they have to undergo structural changes, which will involve a hypertrophy of the smooth muscles and a thickening of the intima, which involves further reduction in the lumen size of these arterioles. An implication of that is pulmonary hypertension due to an increased vascular resistance. This pulmonary hypertension can further cause a compensatory right ventricular hypertrophy, which can result in a right heart failure. Now, due to a hypertrophy, there is an increased right ventricular pressure, and this right ventricular pressure can now exceed the left ventricular pressure, which can result in more amount of blood being sent from the right to the left side. So, the left to right shunt is now inverted into a right to left shunt. This results in two main problems. First, the oxygen delivery to the body is reduced, and secondly, one of the major reasons for sending blood to the pulmonary circulation obviously is to get blood oxygenated, but also there are larger chunks of cells which are present in your blood known as megakaryocytes, which are precursors to platelets. And because your pulmonary capillaries are very small vessels, these megakaryocytes can be broken down into platelets within these pulmonary capillaries. Now, since you have a right to left shunt, instead of sending blood through your pulmonary aorta, the blood is now entering the normal pulmonary trunk. It is now entering into the aorta, which results in no blood being sent, or the reduced amount of blood being sent to your lungs, which results in something known as thrombocytopenia. The major function of thrombocytes in the body is formation of a platelet plug and hemostasis. When there is thrombocytopenia, this can result in spontaneous bleeding events, which depending on the severity can result in epistaxis, dental bleeds, menorrhagia or pulmonary hemorrhage. Reduced oxygen delivery will implicate itself as hypoxemia, which can result in compensatory polycythemia and fatigue. And polycythemia increases the blood viscosity, which can result in a pulmonary embolism, a stroke, or a deep vein thrombosis. We now move on to cyanotic defects. Tetralogy of Fallot was for the very first time clinically explained by this fellow named Fallot in the year 1888, and he described the condition on the basis of 4 specific traits. These include a ventricular septal defect, a right ventricular outflow tract obstruction, which refers to pulmonary stenosis. You have an overriding aorta and a right ventricular hypertrophy, which is again a compensatory mechanism to deal with the other 3 features. And the primary defect in this case is that conotruncal septum during formation shifts slightly anteriorly or in any direction really, which results in pulmonary aorta, the lumen of pulmonary aorta being reduced in size, and the aorta, the pulmonary trunk being reduced in size, and the pulmonary and the major artery, which is the aorta, having its lumen being increased in size, which results in the other features as well. Moving on, we have the transposition of great vessels. Great arteries involve aorta and pulmonary trunk. And when there is a defect in the conotruncal septum spiraling or in neural crestal migration, it can result in a ventricular arterial discordance, which basically is to say that your right ventricle has to open into the pulmonary trunk and your left ventricle has to open into the aorta. However, because of this defect, the right ventricle now opens directly into the aorta and your left ventricle is going to be opening into your pulmonary trunk, which is a problem. This condition may also be associated with situs inversitus, which is where there is a laterality mentioned throughout the laterality which is maintained throughout your body with respect to the organs and the way that they develop. In situs inversitus, this is reversed. So your liver, instead of developing on the right side, will develop on the left side. Not developing on the left side, will develop on the right side. And the apex of the heart, which has to be present towards the left side, will now be towards the right side, so on and so forth. The prevention of these conditions, obviously, since these conditions are chance occurrences, saying that you can prevent them is pretty redundant. However, there are certain triggers that you can prevent. So as to prevent these conditions from occurring. That involves folate supplementation, controlling gestational conditions like TNMC and preeclampsia, avoiding teratogens like nicotine, alcohol, anticonvulsants, and isotretinoin, and timely prenatal monitoring so as to be able to manage these conditions better. Diagnosis will involve ECG, which is the most preferred method of diagnosis, but you can also go for a chest X-ray or a cardiac MRI. This is a picture of a cardiac MRI, rather a body MRI, which is exemplifying situs inversitus. So you have your liver on the left side, you have your stomach on the right side, and the apex of the heart, which is directed towards the right side. And this is a chest X-ray, which is showing transposition of great vessels. Treatment will involve medical and surgical interventions. Medical interventions are to be complementary to surgical or catheter-based interventions. This will involve beta blockers, standard heart failure regimens, and anti-arrhythmic agents. While surgical interventions will involve a single patch repair, classical open thoracotomy, and VATS, which is video-assisted thoracoscopic surgery. These are 3 of many interventions which can be done. Single patch repair involves, it's usually done for an AVSD, that is an atrioventricular septal defect. And in this, you take a patch of pericardium and you insert it in the VSD which is present, and you try to close the patency of that opening. For a classical open thoracotomy, it's usually not preferred now because it's a more invasive technique, and you do have more minimally invasive techniques that can be used in place of these, which involve catheter-based interventions. This is essentially where my presentation ends, but now I'd like to move on into a rather interesting aspect of this presentation, which is, so there was this case that was reported in the year 2024 in this journal known as Frontiers, I'm sure you've heard of it, on cardiovascular health management. And the case was pretty interesting in the context of the fact that it showed the interaction of 2 very rare congenital anomalies and what that can result in the form of complications. The interesting part was the fact that even after all of this, the patient actually had a pretty good prognosis, and according to the follow-up, the patient is going to survive for a pretty long time. So let's see. The mother, who was the patient who came in, was aged 28 and her gestation age was about 24 weeks and 6 days, so 25 weeks. The prenatal diagnosis was a combined dextrotransposition of the great arteries, With a ventricular septal defect, we know what that is. Pulmonary stenosis, we know what that is. What is a double aortic arch? A double aortic arch refers to, usually what you see is, if this is your ventricle, and this is the pulmonary trunk which is arising, and this is the aorta which is arising. Usually the aorta forms an arch over here, and there's a trachea which is present posteriorly. And in double aortic arch, what happens is I'll show this diagram. What happens is over here you have the trachea which is present over here within this lumen, and the aortic arch divides into two aortic arches, and this results in, obviously, since the trachea is getting compressed between the two arches, it will result in difficulty. It will result in difficulty in breathing, dyspnea, breathlessness, and if it extends posteriorly, if the compression extends posteriorly, it may also result in dysphagia. So, A and B over here refer to the superior and inferior aspect of the X-ray which was taken, and C and D refers to the right and left position. EFG is interesting because it shows a 3D cardiac remodeling of this condition, wherein the blue part is your trachea, and the right and left aortic arch are forming a vascular ring around this tracheal tube. But another interesting thing to note over here is, instead of the normal way that your vessels arise from the aortic arch, what happens over here is there are separate vessels which are arising from each arch. So here the right aortic arch is giving rise to the right common carotid and your right subclavian, and the left aortic arch is giving rise to the left common carotid and the left subclavian. Because of these multiple heart defects which were present, along with that we also had a symmetrical aortic arches and eGVNS separate arteries, along with a subpulmonary VSD and a pulmonary wall dysplasia with a right outflow tract obstruction, which again means a pulmonary stenosis. The result of this was a lot of different complications which involve not only the result of these features, which involve severe acidosis, hypercapnia, dyspnea, respiratory distress, and increased lactate levels, which if you think about it, will be a consequence of the amount of respiratory distress that the patient is undergoing. Along with that, because of the number of surgical interventions that the patient had to undergo, which involve an aortopexy, a tracheopexy, an atrial septostomy, and so on and so forth, the patient had to undergo long-term hospitalization, which resulted in a lot of iatrogenic infections like that of Klebsiella pneumonia and Enterobacter. So to deal with that, the patient had to undergo a lot of antibiotic treatment, and the result of that was ischemic lesions, because due to the amount of respiratory disease the patient was undergoing, there was hemorrhagic lesions that were observed during a brain MRI in the follow-up. The follow-up also involved the patient was found to be stable with developing a mild neo-aortic insufficiency with a mean pressure gradient of 10 mmHg. What that basically means is there is something called the Rushkin procedure, which is the atrial septostomy I mentioned, in which the procedure basically involves, if this is your septum which is present between the chambers of the heart, and there is respiratory distress that the patient is undergoing. So what you do is, within the septum, you make a hole so as to facilitate mixing of blood within these ventricles and reduce the amount of oxidative stress which is present in the body. You also have something known as I mentioned, tracheopexy and aortopexy. Aortopexy refers to fixing the aortic arch anteriorly on the posterior sternum so as to prevent the compression which is happening on the trachea. And this condition, because it was seen with tracheomalacia and bronchiomalacia, tracheopexy was done, so that basically means you fix your trachea in a way to the surrounding structures and to the thoracic walls to prevent collapse of the trachea. Sorry. The follow-up also resulted in finding out that the patient, what I found out from reading the paper is, the conclusion was, it really is a testament to modern medicine how far we've come that we're able to deal with as many cardiac anomalies and have the patient live up to a pretty good age. Now, this was obviously a case done in 2024, which means that the patient is about 2-3 years, but even the fact that the patient survived these many surgical interventions is truly a miracle, and it was something that I found personally very interesting. And that's it. Thank you very much.